Today I'm with Dr. Shirley Schlessinger, and Dr. Schlessinger is in charge of the graduate medical education programs here and that department and that office. And we're going to be talking to her about ACGME and all things that are related to residency accreditation. So first, Dr. Schlessinger, I'd like for you to tell us basically what your job is and what your office does.
Okay, so I have the privilege of being the Associate Dean for Graduate Medical Education in the School of Medicine at the University of Mississippi Medical Center. It's actually a dual role. My second title is the Designated Institutional Official, and they're not always the same person, but in many places across the U.S. they are. The DIO role is really about making certain what's happening in the clinical world and the hospital aspect of graduate medical education. The Associate Dean role is more a role that's responsive specifically to the school side. And graduate medical education is a little bit different animal than some of the other education pieces in medicine, because graduate medical education is a reference to the training that people do after they get the MD degree, but before they are eligible to be licensed independently and practice. And so in that role, and it can vary from 1 year to as many as 7 years, depending upon the specialty area they're training in, but in that role, they really are a dual citizen. They are both a student, and so are enrolled in the School of Medicine. They are also an employee of the hospital, and they are actually paid to provide care to patients within the construct of their program and under supervision at all times. So my role in this institution is to oversee, we currently now have 54 accredited training programs in graduate medical education. They range from what we call categorical or core internal medicine, core graduate medical education programs. These are programs that you finish medical school, you get your MD diploma, and then you walk in the door and start in one of those programs. So they're the first step, the categorical programs. We have 27 of those. The remainder of our programs are advanced training programs in which you have to do some amount of core training, usually a minimum of 3 years, before you can then train in a subspecialty area. So for instance, if you want to be a cardiologist and manage heart patients, you must first complete internal medicine as your categorical program before you move on. So my responsibility is for the residents and making certain that they're doing the right things they should as an employee, but also oversight for their programs to make sure they maintain accreditation and remain in compliance with all of the standards that are mandated at a national level. Any trainee to be eligible for board certification in their specialty area must finish from an accredited training program. So it's a really critical issue for our organization and for our institution that we maintain successful full accreditation of all of our programs. Does that answer?
Yes, that's exactly what I was hoping for, and I didn't realize we had so many residency programs.
We continue to grow. I moved into this role 12 years ago now, and when I moved in, and I used to do talks like this, we had 34 programs. So we have actually added 20 programs in the last 12 years. The majority of those have been in subspecialty areas, so we now have pediatric cardiology and allergy immunology, and a few are what we consider primary programs. We've added radiation oncology and dermatology just in the last few years. So lots of growth and training. Our focus continues always to be providing caregivers for Mississippi, and these are all areas that we are underserved in terms of practitioners across our state. And the vast majority of people that finish if you go to med school here and then you do residency training here, you are about 80% likely to then practice in the state of Mississippi.
So could you talk for a minute about the overall ACGME accreditation, and then about each program's accreditation? For example, when does that happen? What does a schedule look like? And how do you manage all of that?
So it's it's an interesting time right now in the world of accreditation for GME. So for the last, and I've been involved maybe 30 years now in medicine and training and stuff, and for the last 20 years at least, there's been a pretty standardized way these things happen. In each specialty area, there are representatives at the national level that work voluntarily for this Accreditation Council for Graduate Medical Education, which is the accrediting body, the ACGME. And each specialty area worked to define their own standards for what was expected in their training programs. And they also reviewed site surveyor materials and written materials from each program on an ongoing basis, usually every 3 to 5 years, to determine whether or not you were in compliance with the standards they set. So under that overarching framework of the Accreditation Council for Graduate Medical Education, there are all of these what they call resident review committees. Now they're just called residency committees. So it used to be RRC, now it's RC. But so the RCs exist in a lot of different areas. Specialties fall under the core. So there's one RRC that oversees internal medicine and all of the 15 or so subspecialty type programs that fall under internal medicine. And so that's a rotating group. It's not a static group. It's a term of service somewhere between 2 and 3 years, and then new people rotate on, representing different areas of medicine and that sort of thing. All of them are like that. Probably 10 or 12 years ago now, maybe even a little longer ago than that. It was before I got in this role, so maybe 14 years ago. They recognized that there was some inconsistencies between what different residency committees were requiring, and at a national level we realized that there should be some basic common program requirements that apply whether you're training to be a plastic surgeon or an OBGYN or a family medicine doc. And so at that time they pulled pieces from all the different requirements, they put a core group together that defined those common program requirements, and those became a base for every single program. And that was actually, I know exactly what it was actually, it was 2000 to 2002. And during that time period, they also recognized a need to define what really makes a physician competent, because we're taking people out of medical school where they've gotten this core base, knowledge base. Now we're trying to get them competent to practice as a physician in a specific area. What are the things we're looking at to define a competent physician? And so as part of defining the common program requirements that would apply to all specialty areas, they defined competency domains that they basically said, doesn't matter what kind of physician you are, but you need some basic competency in these areas. And at that time they defined actually 6 domains. 4 were things that everybody involved in medicine made sense. We'd been grading residents on these things for years. They were medical knowledge, and obviously that's testable, that kind of thing. Patient care, how do you perform at the bedside on the ward? Communication, how well do you communicate with each other, with your patients, with your families, with the nurses, all those pieces of communication. Professionalism, what kind of personal integrity do we have? How well do we do our charts and our duties that are related to professionalism, those kinds of things. Those were the 4 that we've been grading people on for years and years. They added 2 new ones that were things that we really had never focused on in medicine, and in the 15 years since that time, these have become really big pieces and actually have now sort of fed into the huge focus on quality improvement and patient safety that we have in medicine globally, and especially in residency education. One of those was systems-based competency. So how well do you work in the healthcare system? Do you get the social worker involved when you do? Are you aware of what the physical therapist can do for your patient with back pain? Those sorts of things. How well do you use the systems? And then the other piece is called practice-based learning and improvement. And it's basically about, can you look at yourself and your team and determine how you can do things better? And so, that whole concept of being a lifelong learner and always improving was sort of pulled into that. And so beginning in 2002, 2003, every residency program in the nation was expected to develop methods to assess and determine competency in each of those defined domains. There were some general guidelines given, but it was actually up to the individual program, and a lot of your accreditation was basically answering, how do I make certain my residents are competent in this? How do I teach them this? And there was also sort of a new push at that time, was that it shouldn't all be didactic. You know, you don't sit in a room and lecture someone on professionalism and expect them to be competent in that. You have to have ways that you allow them to demonstrate that they're competent, that you give them feedback, that whole feedback cycle and that sort of thing. So that's really where the competencies got implemented. That's where we had this big shift to common program requirements. Now for the next 12 or 13 years until 2013, 2014, we continued with the old cycle of 3 to 5 year visits every 3 to 5 years, and that was dependent upon how compliant you were. So if they came and you were really working hard to do all of the things well that they expect you to do, recruiting, teaching, evaluating, patient care, each of the competencies, all of those things, they would say, we're going to come back and see you in 5 years. And in 5 years, you did a whole bunch of paperwork, you sent it in, and then they sent an individual surveyor who would come and spend a day at your program, interview your residents, interview your faculty, interview your program directors, look at your files, look at where you had documented conference attendance and where you had evaluated the residents and evaluated the faculty and evaluated the program. And it was really a document check that went back to that home residency review committee, who then issued a decision based on the paperwork you'd given them and the report from the site surveyor. Generally, you could get really 3 levels of accreditation: continued full accreditation, accreditation with warning, and you would have citations that you needed to address, or a probationary accreditation. And again, that would put you on a short cycle, 1 or 2 years, and they'd come back, and you really needed to address things. There was also the potential for a withhold accreditation. We've never experienced that here. Over the last 15 years, I think we've had 5 programs at different times that were on probation. Usually it was related to loss of faculty and things like that, where we needed to rebuild, do some rebuilding, and we've always rebuilt positively without any difficulty. 2 years ago, and it started earlier than that, about 5 years ago probably, we began to really look at, you know, maybe we're focusing, there's lots of complaints from the GME community about all this paperwork and, you know, running around, and, you know, they started looking at it and they thought, just coming every 5 years, there are programs that can really spiff up for that day that you're there and look really good on paper, and that may not in any way reflect what's going on an ongoing basis in your program. And so they really began to think at a national level about how we could be focused more on outcomes and more on program improvement, and have the whole accreditation process be less of a judgment and more of a formative, supportive experience. And so Dr. Naska, Tom Naska, who is in my mind a very great man, is currently the Executive Director of the Accreditation Council for Graduate Medical Education. And he personally was a huge spearhead leader for this change. He called it the next accreditation system. Well, we're now in it, so I think it's now the new accreditation system, but it's widely referred to as the NAS, next accreditation system. And so the entire world of accreditation in GME changed 2 years ago, and we are still in an implementation phase. It was a 3-year implementation phase, and so by the end of 16, all of our programs will be in the new next accreditation system. And it's changed in that we no longer are getting cycles of 3 to 5 years, and we're no longer even being site surveyed every 3 to 5 years. We are now doing paperwork annually that's all electronic, but we update information on previous citations and major changes in our program that happened over the previous year. We report on an annual basis the scholarly activity of our residents, the scholarly activity of our faculty, the attrition of our residents, who we've lost, who we've gained, that sort of thing. Some duty hours information, some competency information. That's entered every year, updated every year. And in addition, they direct survey from the Accreditation Council on Graduate Medical Education. They direct survey our faculty in our programs and our residents in our programs. And you have to have at least 75% of your people participate in the surveys. We do not immediately get the information from the surveys. It comes back to us usually 3 to 4 months later, collated, anonymous. And the RRC, still the subcommittee groups, they've not changed at all. In each of their meetings annually, they review that annually reported information on every program in the United States. And then based on that information, they make a decision as to whether or not they see some holes or they see some other things that are problematic. They may ask you to do a progress report, go in and answer some questions about things. But every program now is on a 10-year self-study cycle. So the actual defined planned survey visits are now going to happen on a 10-year cycle basis. Now, obviously, they did in 2013 say, okay, 10 years before we come, so it's graded. So the first visits were anywhere between 3 years and actually 12 years. And I'm pleased to say at the institutional level, our next survey on site from the ACGME is in 2024, currently scheduled, and I do not plan to be here at that point in time. That's past my retirement date, but be that as it may, so they're spread out. Our first 10-year site survey actually is going to be orthopedics. It's coming up this summer. The whole process is different. The date is actually a date by which you have to turn in a self-study. It is not a gigantic LCME self-study. It is a much smaller targeted self-study that is built around doing a standard SWOT analysis like we do in many industries and have been using in healthcare in different areas for a long time. So each program is asked to bring all its stakeholders together to define its strengths, its weaknesses, its opportunities, its threats, to really think about what your particular program, your specialty, mission and goals are. And the reality is, yes, our family medicine program wants to produce good family medicine doctors, but maybe we're looking to really produce academic family medicine doctors or people who specially teach. Our ED program may really want to be producing docs who can be administrative leaders of emergency rooms. So it's really asking programs to think hard about, sort of what your final product, what are you trying to have that be, and then look to make sure that in your SWOT analysis, you're looking at how you're working to meet those specific goals.